Hello everyone, welcome to Pharmacology. We're going to go over a couple of core introduction concepts that we're going to revisit throughout the year. So this lecture is really foundational and it's going to have a lot of terminology and concepts we are going to revisit time and time again throughout different topics. So it's very important from that perspective, and it's a great place to start as far as an intro to drugs. So let's talk about drugs themselves and what they are. Well, drug is basically any type of substance or chemical that's going to affect a biological system. So generally we like to think of drugs as being useful. Certainly drugs can be toxic or poisons too. Generally speaking, that just depends on the dose. So any drug is potentially a toxic substance or a beneficial substance depending on what you're using it for, depending on who the person is, how they process the medication, and how much you give them. That's why it's really important that we dose things correctly and we understand how the body processes drugs correctly, and that's what we're going to talk about during this lecture. So pharmacodynamics is where we'll start. This is what drugs do to the body, if you want to simplify it down. And we're going to talk about a couple different ways that drugs interact with the body. So one of the big things we'll revisit is the concept of receptors. And receptors are things located on cells and different systems in the body that are generally protein structures, and molecules interact with them. So these are things that are already built into our physiology, and by making a drug that's designed to work with a specific receptor, drug designers, drug developers can create a molecule that specifically elicits some kind of a response or blocks something from happening. That's kind of the basics, and that's where we get agonists and antagonists. Agonists are agents that elicit some kind of a pharmacologic response. There's also such a thing called a partial agonist, which is exactly what it sounds like. It elicits a partial response, so you don't quite get the full effects of a normal agonist, but you do get some partial effect, which can be advantageous in certain situations, which we'll talk about as we get to there. It's actually quite rare, so don't feel like you have to spend a ton of time trying to figure out exactly what the difference of a partial agonist is. There's really only a couple examples of them in modern medicine that we really use regularly. Most of it is just sort of interesting to talk about from a scientific perspective. Antagonists would be something that basically is like a blocking agent. So a lot of the drugs we say are blockers, like beta blockers, alpha blockers, etc. What those are going to do is actually sit on that receptor and prevent any type of endogenous substrate from interacting with it. So for example, a histamine blocker would work to prevent your body's natural release of histamine during an allergic reaction from interacting with the receptors. Therefore, you don't get as severe of allergic symptoms in a particular situation. And so basically this is going to create a non-pharmacologic response. It's not going to do anything. You're just going to put it on the receptor, but it's going to prevent the body from doing something. So some drugs that block receptors, you might not even, if you gave them to a person without a disease, they might not necessarily know they're taking it. Other ones will have pretty significant impact on the day-to-day life of that person, depending on how active those endogenous systems are. But the point is that an antagonist isn't actually doing anything in the body. It's just preventing the body from doing something it normally would in a day-to-day situation. There's lots of different types of antagonists. Functionally, they all basically do the same thing. There's a lot of different terminology here. So classically, an antagonist is going to bind to a receptor and not do anything, just like I just said. There's also competition of antagonists. So it might be competing with an endogenous substrate, or it might not be competing. Maybe it binds to a different site. Receptors are complex proteins. I think of them in my head as like a little square or circle or something, which is kind of ridiculous, but that's how all the drawings are done. But really they're much more complicated than that, and they have lots of different areas on the structure to bind to the specific, to have multiple binding sites. So you might design, if you're a drug developer, you might design a drug that's going to bind to a receptor and prevent it from acting without actually competing with endogenous substrate, because maybe it's more efficient to do it that way. Then you don't have to worry about the endogenous substrate maybe binds better than your drug you developed, and then they kind of fight for binding, and if that endogenous substrate gets there, your drug's not as effective. So some drugs are designed specifically to bind to separate sites that aren't maybe the primary site on the receptor, and then create a downstream effect that way by blocking the receptor. Reversible versus irreversible. Some drugs can bind to a receptor and then they sort of dissociate and then rebind with it. Other ones will bind and then they're kind of locked in and for the lifetime of the drug. Eventually the receptor will clear the drug or the drug will degrade or get metabolized or something like that. But for the most part, that's the two things. I don't think, again, I wouldn't really get too worked up about reversible versus irreversible. It sounds like it's a big deal, but functionally it really doesn't make a whole lot of difference. And it's not like, oh, that's a reversible drug. There's a couple caveats to that we'll come back to, but for the most part, it doesn't really matter. Functional antagonist is something that elicits some kind of a pharmacologic response in the body that blocks a certain or works against an endogenous pathway. So functionally, it antagonizes a certain system, but it doesn't necessarily block that system specifically. Sounds kind of complicated. So a functional antagonist might not actually be a real antagonist, which is confusing too. You might have an agonist that elicits a pharmacologic response in one area of the body that functionally antagonizes another area of the body. And that's what we're going for with the pharmacologic effect. So a little confusing. But the point is you have two kind of core concepts when it comes to receptors. You have agonist and antagonist. One is we're promoting a pharmacologic response. We're basically pushing the body's levers and trying to make something happen. Antagonist is we're trying to block something that's going on in the body that we don't want to happen. My last bullet point on this slide is dirty versus silver bullet. The one really important thing to say is that there are very few drugs out there that really just act in one physiologic system. They're mostly going to have unintended consequences or what we call side effects. And so that's where we get things like, well, I take this drug for my depression, but it makes my mouth really dry and causes constipation. Well, obviously we didn't design the drug with the intent of giving you constipation or dry mouth. It just happens to be a side effect because it acts in the GI tract on cholinergic receptors as an example, which we'll talk about later in the course. So with that in mind, you have dirty drugs or silver bullet drugs. And these are just terms I kind of made up myself. I like to think of like a dirty drug as something that works on a lot of different receptors. It doesn't have a very clean pharmacology behind it, whereas a silver bullet basically like works on one specific set of receptors. And again, we'll talk about different drugs like that. And the more silver bullet approach you get, the more tailored you get to a specific disease. And generally speaking, the less side effects you have. However, sometimes that approach doesn't work as well. And you want a more broad approach to targeting multiple different receptors for different conditions. So it really depends on what you're treating. There's not like one better than the other, but I just wanted to point out that drugs are do go all over the body. Most of them do get absorbed. They go into multiple different tissues throughout the body. They will have lots of different effects. Now, again, we can try and mitigate that because maybe you need a certain amount of a dose to actually experience side effects, but you can actually get therapeutic effects with that same dose. So the question is, how much do you give somebody to give them the get the therapeutic response you want versus giving them too much and causing adverse effects. A couple more terms just to touch on briefly. Affinity is the tendency for a drug to bind to a receptor. So when I say something has really high affinity for a receptor, it means it's very likely to bind to that. So a good example, I'll go back really quickly and just point out partial agonist here. So a good example is the partial agonist called buprenorphine, which is part of Suboxone. You may have heard of that brand name. Suboxone is a popular drug. It's a combination product that includes buprenorphine and another item, and it's used for opioid dependence. And the cool thing about buprenorphine is it's a partial agonist opioid. So by taking it, you get some basically light opioid type effects from it, but you don't get like the full-on euphoria like you'd experience with injecting heroin. And if you did happen to inject heroin while you're taking buprenorphine, buprenorphine has a much higher binding affinity than basically any other opioid out there. So it's going to be very difficult for those opioids you might ingest or inject or smoke or whatever to get to that site of action because that buprenorphine is bound so tightly on that receptor. Even if it does get there, it's not going to be able to knock off the buprenorphine. So that's a nice deterrent for people who are abusing opioids as an example of why high affinity does matter in some cases. Again, in most cases, we don't really care about that because you aren't usually giving two substances that are competing like that. But we do have some situations where that happens. Potency is exactly how it sounds, and we don't really have to talk a lot about potency, but potency is affected on the chemical level through different types of bonding and basically the interaction between the drug molecule and the receptor. And really, when it comes to potency, there's not much for us to do because all the work's been done for us in different stages of clinical trials. They figure out which types of doses work the best, and so we just have to follow the dosing guidelines that the manufacturer provides. And basically, the only difference you're going to find with potencies is that some drugs are more potent, and you're going to give smaller amounts of them relatively to lower potency drugs that you're going to give higher amounts of. So you might have two drugs in the same class, and one you give 100 milligrams a day, and the other you give 10 milligrams a day. Well, the 100 milligram one is probably less potent, and potency can have a number of effects, or be caused by a number of different things. Efficacy is just a term we use to define a drug's ability to produce a biological effect. So when we talk about a drug must be efficacious, or if it must be effective and safe, that's kind of the key behind drugs getting to market. That's what we're talking about here. Doesn't necessarily mean anything. Doesn't mean the drug's more potent than another one. It just means it has been studied to be effective to producing the desired biological effect. And there's specificity versus selectivity. This is a little confusing, but simply put, highly specific drugs will bind to one type of receptor, and highly selective drugs will act in only one place of the body. So you can have a drug that may act specific, meaning it only binds to one type of receptor, but it's not selective because those receptors are located all throughout the body, kind of like what I was talking about on the other side. So again, a lot of this stuff doesn't really matter for us, fortunately, as clinical healthcare practitioners. We don't really care too much about this because, again, once a drug makes it to market, all this stuff has been kind of worked out, and we know and understand that the doses are standardized at that point, hopefully. So, again, it's just some background information. All right. Next, I just want to go through a couple of different visual representations of some of the things we talked about. So agonists, just a representation of concentration versus activity percentage. So the more, basically this just means, think about like blood concentration, how much drug is in the system at any given point. And this is the activity you're getting on any given receptor within that system. So you give enough drug, eventually you're going to get close to 100% activity, but at the same time, the question is like how much can you give and have side effects, and we'll talk about that here in a second. But the point is that if you give enough drug, you're going to hit a point where you saturate all the receptors and you have complete activity. You're going to level out at some point. Partial agonist, on the other hand, is not going to activate the receptor fully, or not all the receptors, so you're going to end up with sort of a halfway rate limiting system. Again, we don't really care too much about that because there are only a few partial agonists, and we care more about why we use them, not necessarily how they work. I know that sounds kind of silly, but in clinical medicine, we're sort of beyond that. How does it work? What's the pharmacology? I know this course is called pharmacology, but we're really talking about how do we apply these concepts to actual healthcare. So yes, the background's good. And if you really want to read more about some of the nitty-gritty pharmacology stuff, the book has a lot of really good in-depth discussions on that, but for the most part, we're going to skip over some of that stuff. To talk about antagonists, you'll see these concentration activity relationship graphs sometimes done if you ever read like a clinical trial about a medication, and this is just showing that things kind of work on a logarithmic scale. And so if you're giving the medication, eventually you kind of hit like a threshold where it just like we just showed, it's going to hit a point where it can't really do any more than that. And there's going to be some dose in the middle where there is sort of a flatlining effect. Now here's what happens if you gave an agonist and then you gave it an antagonist at the same time. You're going to require more of that agonist in the system to overwhelm the antagonist so that you can actually get an effect. Remember, that antagonist might be sitting on that receptor. So eventually if you give enough of something, it's going to push off or possibly push off that antagonist. So that's one effect you might see. Talking about different types of receptors, again, this doesn't really matter a ton, but it is important because things can work on the same type of receptor but work differently. So an example of a basic transmembrane signaling receptor. A lot of receptors are what we call G protein coupled. So again, you have this receptor that's kind of this chunky protein that sits in the cell membrane here, and your drug comes in and interacts with it. Now, in a normal setting, you have this is the example they gave here is a dopamine receptor. So dopamine receptors are in the blood vessels, they're in the kidneys, they're in other places. So if your body has dopamine floating around, it's going to interact with this receptor, and it's going to produce a downstream effect. So it stimulates this G protein system, which is going to stimulate adenylyl cyclase and protein kinase C, which in turn opens up a potassium channel. Opening up a potassium channel causes the ability to have an action potential. So that's what the effect is in that particular system, and then it sort of causes a chain reaction from there. So that's how signaling works generally with a G protein coupled receptor. Now, if you block this with an antagonist, dopamine can't interact, therefore none of this happens, and your channel stays closed at that point. Alternatively, you could look at the actual channel itself. So you might be thinking, well, why block that receptor and stop the sodium channel from opening when you just block the sodium channel directly? Well, kind of. Here's 5-HT is an abbreviation for serotonin. So serotonin, I think we think of that as a mood-related neurotransmitter, but it's also associated with nausea and GI-related things and a number of other systems as well. But anyway, here's an example of serotonin binding directly to the sodium channel and causing it to open. So this is a ligand-gated ion channel. It doesn't have to work through the G protein coupled system. It's simply just working directly on the channel itself. And the antagonist is doing the same thing, but then by the antagonist binding to this specific site, you can't get the channel open because serotonin cannot bind to it. So in this case, you'd be blocking the activity of serotonin in this particular system. Some other things. So those two slides I just showed you are probably representative of the two major ways that drugs interact with receptors. There's a couple other ways drugs work. Enzymatic inhibition is a pretty common thing too. So basically, you get an enzyme and you have substrates, and they combine and they produce an end product. Pretty simple. In this case, you have a drug that interacts with the enzyme. So instead of the substrate, the drug is binding in its place. The enzyme drug complex can no longer make anything. So this is an example of possibly bacteria that makes an enzyme that produces something that causes it to be resistant to certain drugs. So maybe it produces what we call beta-lactamase. If you've heard of beta-lactamase producing drugs, you will soon when we talk about antibiotics in the next couple of lectures. So the idea here is that you can prevent this complex from producing the actual end product, which is going to break the beta-lactam ring of that particular antibiotic, by giving a drug that binds to it competitively and prevents the complex from forming the end products. Therefore, you prevent that bacterial enzyme from producing something that's going to break down your drug. So basically, you're giving a drug to protect the other drug you're giving, which we're going to talk about during antibiotics a little bit more. That's one kind of clever way that we can use drugs differently than just receptors. I talked about competitive versus non-competitive antagonism. Doesn't really matter in the long run, but basically the idea is illustrated here just to review what we're talking about. So you're looking at a site of action. So again, you've got your natural ligand or your neurotransmitter hormone, whatever it might be, binding to this site. And instead of, so competitive antagonism would be that your drug is binding directly to that same site. So it's fighting against the endogenous substrate to get into that one binding site. Now, non-competitive would mean that you have your antagonist drug binding to a separate area, and then that actually either prevents this from binding altogether. In this drawing, they've shown that it does bind, but produces a partial effect. So basically, it's causing a signal still. Some sort of cellular effect is happening. It's just not as prominent as it would be with the actual normal binding site being taken up by the drug, or excuse me, by the endogenous substrate, and the drug not being present in the system. Again, for our purposes, not super important because it's more or less about how the drug actually works and how we apply that clinically. So whether it's competitive or not, sort of like, well, that's great, it's competitive, but does it actually work to lower that person's blood pressure, in a clinical trial? That's what we really care about. But first we have to get there, and this is really the background here. Drug concentration response is a really important concept. What you have here is a pretty typical curve looking at concentration. So this is your blood concentration of how much drug is in the system over time. So this is, let's say you take an oral dosage form. It takes a little bit of time to get that medication into the system, so it has to go through the GI tract. And once it hits its peak absorption and peak concentration, then your body eliminates it. We'll eliminate it for a number of different pathways, which I'll talk about here in a couple of minutes. But what you have here is area under the curve and a brief period of time in which the drug is at highest concentration, and that represents ideally where your effective time frame is on the medication. So let's say this is a 4-hour window, and once it drops below this concentration, it's really not in the body in enough amount to cause any therapeutic benefit. So you would redose at this point. So you redose sometime in here so that your peak kind of comes up here, and then you would repeat. And so that's the idea behind where dosage intervals come from. Now this could be an hour, a day, a week even. Doesn't matter, depends on how the drug is eliminated. So that's a big step. But this is the basic concept between what happens to drugs when they go in the body. You get concentration, your body eliminates them. Over time, the drug leaves the system. Now what we don't want is for this peak to get above here. These acronyms aren't really standard. This stands for mean toxic concentration and mean effective concentration, which again aren't really real things. But therapeutic range or therapeutic index is a correct term. So that just means that's our goal window to get the concentration between. We want to be within that therapeutic range without going below it for too long of a period of time, or staying above it for too long of a period of time. Above it's going to cause side effects. Below it is going to diminish the efficacy of the medication. So really when it comes to dosing the medication, that's where dosing guidelines are really important to follow, because they've been studied to understand the kinetics of the medication and how the drug's processed to make sure that there's enough that stays in the system to provide the intended effect. This is kind of just saying what I just said. Again, a little different way. The terms you might read of that are more common are ED50, TD50, and LD50. ED50 means effective dose of 50% of the patients. TD50 is toxic dose of 50% of the patients. LD50 would be the lethal dose of 50% of the patients. Most drugs, we're not going to see a lethal dose. It's going to be very, very high. You have to take an extremely large amount, maybe an incredibly large amount, unquantifiable amount of medication to actually cause a lethal dose in somebody, which is good. There are some drugs that are, of course, more dangerous, but generally speaking, what you're looking at is the effective dose of 50% of the patients to the toxic dose of 50% of the patient, and that's your window of opportunity there. That's sort of where you're targeting, somewhere in there for your concentration. Are you going to get side effects in some patients? Absolutely. Are all patients going to be fully treated with that? No. And that's really the tricky part, is finding that balance. So some patients might require a lot higher dose than another patient. Other patients may be much more sensitive to side effects than some patients. So patient individual variability is going to be a huge component in how you dose the medication, but at least you have a frame of reference to start, and that's based on some of the studies that look at this in animal models and then ultimately human models during drug clinical trials. And then therapeutic index, here it's written off as the margin of safety, which again is just that window of opportunity. So when I talk about therapeutic index, the terms I'll use are often I'll say it has a wide therapeutic index or a narrow therapeutic index. What that means, a narrow therapeutic index means that there's very little wiggle room. Your goal is tight, so you don't have a lot of range within that blood concentration to get to the effective dose. And once you get there, you're almost at the toxic dose. So it's very difficult. And some of those drugs require a lot more monitoring than other ones, just to make sure that we are in that correct window of safety there and efficacy, that balance there, called the therapeutic index. Some drugs will have a wide therapeutic index where really a small amount of the drug is effective in most of the population, and it takes a lot of drug to cause toxicity. So again, you might have very little side effects, very good efficacy, and that's more of a wide therapeutic index medication. Drug concentration and response. So generally speaking, if we want to sum it all up, you increase your dose, you increase your concentration, which increases your pharmacologic response, but also starts to put you at risk for increased side effects. So a good way to think about the vast majority out there of drugs, if you double your dose, you're doubling your blood concentration. We're going to talk about some linear kinetics and things like that, and I'm going to talk about vancomycin when we talk about antibiotics. But the point is that usually things move in a linear fashion. Now, there are some examples to that, which I'll show you in a second. But for the most part, it's pretty basic stuff. Like when you think about the math and the chemistry and everything behind it, increase your dose, increase concentration, get a better pharmacological response, possibly increase your risk of side effects as well as you move towards that toxic dose, 50%. NonLinear kinetics, there are some medications that have more of an exponential curve. So PHT here stands for phenytoin. Phenytoin is an anti-epileptic medication. It's sort of the hallmark poster child for nonlinear kinetics. One of the reasons why it has a nonlinear kinetic response is because it's highly protein bound, so it's bound a lot to albumin, and if you oversaturate those binding sites on albumin, you can get significantly higher free levels of phenytoin, and that can go up pretty drastically. So it's always sort of a notorious thing to ask on pharmacy boards and stuff. If you increase the dose of phenytoin, if you double it from 10 to 100 to 200 milligrams, are you actually doubling the blood concentration? No, you're probably more like quadrupling it. So that's something to think about. There are some drugs that don't follow those specific rules. So phenytoin's one where we may do some monitoring on to make sure that the blood concentrations are right where we want them. Because not only does it have this nonlinear kinetic profile, it also has a narrow therapeutic index too, so it's pretty toxic even in smaller doses. So that's another reason why we watch that one particularly. So that's kind of a hallmark one. There's a couple other ones, but this is probably the biggest one that gets used on a regular basis. That matters. There might be some drugs that have nonlinear kinetics that have such wide therapeutic indices. Is that the right word? Indexes or indices that have not really much risk associated with them because you aren't likely to get to that toxic dose even with exponential kinetics. All right. Half-life and steady state, super important concepts here. Half-life is the time it takes the drug to lose 1/2 of its maximum concentration. So you take 100 milligrams of the drug, how long is it until 50 milligrams of that drug is still in your system? We base half-life off, we base a lot of things off of half-life, including dosing intervals and how we study the way that the drug moves out of the body. So there's a couple things to look at for half-life. Generally speaking, once you hit 3 half-lives, so you go 50%, now you're down to 75% of the drug is gone, and now you're down to 87.5% of the drug is gone. So after 3 half-lives, pretty much, you're only left with 12.5% of the drug left, which is probably negligible. It's probably not enough to cause any type of effect. So most people say that, well, after 3 half-lives, you're pretty close to being out of drug. So that's a nice benchmark for how long is the drug going to remain in the system. So practical application of this is you have somebody who came into the ER and they took too much of their insulin. How long is it going to be until that insulin's out of their system? Well, what's the half-life of that particular insulin? And then we can kind of extrapolate off of that. So that's a common thing we'll look at half-life for. And half-life's a commonly documented marker within any drug monograph. You should be able to find half-life pretty easily. It's a good thing to be able to look up, and it's a pretty easy thing to find in most systems. Steady state, rate of the drug in equals rate of the drug out. 5 half-lives. So again, 3 if you want to cheat. 5 technically, by the time you hit 5 half-lives, you really are essentially, you're 95% or so eliminated at that point, so it's almost entirely gone. But again, we say 3 is pretty much gone for most people. A steady state is when you're dosing the medication and you hit a point where your body is eliminating it basically at the same rate as you are dosing it. And that happens sort of on a natural level, and it's usually, again, 3 to 5 half-lives of the medication. So here's your time in half-lives. Around 3, you're still kind of going up. By 5, you're pretty flat. And so this is where you're trying to keep your drug within that therapeutic window. So you have, let's say you're side effect line is up here, and your efficacy threshold is down here. You want to keep it somewhere in here. So that's the idea, is that you hit steady state within that time. So you can see that the drug's getting metabolized here. You give another dose, getting metabolized, give another dose, and then eventually you hit steady state. Steady state will occur. You don't really have to, again, this isn't something you have to really think too hard about. It's just the way it works. But it will occur as long as you're keeping your dosing interval consistent. Now, if you start altering your dosing interval and pushing things up and changing things around, you can see bigger spikes and more aggressive, and that's going to take you out of steady state. But keeping the dosing interval the same. One important thing is understanding that this is half-life based. It's not based on how many doses it is. So you might dose a medication every 8 hours, but the half-life is 12 hours. So that's something to think about too. Oh, I gave 3 doses of that medication. It must be at steady state. No, well, what's the actual half-life of it? That's the important step. Okay, let's talk about pharmacokinetics. If you're struggling with half-life, or any of those steady state, we're going to come back to these concepts a lot throughout the year. So I'll be illustrating this using real drugs frequently. If you have further questions and want to post on the forum or reach out, feel free to do that. But hopefully you're kind of grasping that basic concept of what half-life is. Okay, pharmacokinetics. Pharmacokinetics are what the body does to drugs. It's sort of like us pharmacists specialize in this, sort of our thing. So kinetics the basics are ADME, absorption, distribution, metabolism, excretion. We'll go through each one here. So absorption, drugs must get into the body somehow. This is going to be all over the place depending on what the product is. Basically, if there's some way to get it into the body, there's a drug for that. From typical oral dosage forms like pills and capsules, to inhalers, to sublingual or buccal, where it actually stays in the mouth and absorbs that way, to creams, ointments, topical things like that. Eardrops, eye drops, subcutaneous injections, suppositories. Here's former President Obama getting a flu shot, so that's IM. You have transdermal patches that can be done, which is a little bit different than a topical cream. Transdermal is creates more of a depot effect within the subcutaneous tissue and the muscular tissue, and then sort of leaches into the body slowly. It's kind of a cool way to get medication in over a long period of time. And then, of course, you have intravenous. So everything is based on how fast the drug gets into the body, which way you're giving it, and how much is absorbed. So that's some of the more important things we'll talk about throughout the year. Basically, if you give something intravenous, it's what we call 100% bioavailable. You give 10 milligrams of a drug directly into systemic circulation, that's 100% concentration. You hit your Tmax basically instantaneously. Every other way you give medications, you lose some either by it not all getting into systemic circulation, or perhaps it gets metabolized. There's some esterases and other compounds in muscle tissue and fatty tissue and through the GI wall and other things like that that can metabolize drugs before it even gets into the body completely. So what you have is a number of different options here to give medications on. And as far as bioavailability goes, it's all important to understand, but you don't really need to think too hard about it, because again, other people have done all the work for you. So, and me, I should say too, not just you. So if somebody has a suppository that's to market, you don't really have to think about, well, does that medication actually absorb rectally? Well, the FDA wouldn't clear a suppository if it didn't absorb at all. So that's one thing to think about when it comes to this stuff, is that this stuff's been tested. But it's still important to understand this, because it does change patient to patient. Like if somebody doesn't have a lot of muscle mass, an intramuscular injection might go into their body quite a bit differently than somebody who has a lot of muscle mass. Or a sub-Q dose. Somebody has a lot of adipose tissue, a sub-Q dose might absorb differently than somebody who is relatively thin. So with all this being said, you can get pretty close to 100% with a lot of these, even oral. Some drugs are highly bioavailable when taken orally. Others are not at all. But you might read about it and be like, wow, this drug's only 5% bioavailable. Yeah, but we dose it appropriately. So we give 100 milligrams of it, but we only need 5 of that to actually get in, because that's all that's needed to be effective in the body. So we take that into consideration. Fastest onset should be IV. Some people argue that inhalation is the fastest onset, but you could kind of go back and forth on that a little bit. But either way, IV is the only way to guarantee that all your medication is getting into the system completely. Everything else has some losses associated with it. First pass metabolism is a really important concept. So I talked about that every tissue has some compounds in it or enzymes that might break down drugs to a certain degree, and that's true. But the biggest metabolizer of medications is your liver, and that's going to be responsible for the vast majority of all metabolism that happens. So let's take a normal oral dosage form. You take it, it goes into the drug, or excuse me, the drug goes into the GI tract, goes to the gut wall. You lose a little bit in the gut wall, again, esterases and whatnot, other types of enzymes in there breaking things down. It goes into the portal vein. Portal vein goes directly to the liver and then into systemic circulation. Now, anything passing through the liver is designed to break down various compounds. There's tons of enzymes in our liver that specifically break down different things we ingest, and drugs happen to be some of those. So it's kind of interesting that we have all these liver enzymes, and they actually are what break down the medications that we synthetically make in labs. So I think that's kind of cool that our body is just designed to respond to different types of chemicals that we ingest, almost like it knew ahead of time what we were going to be doing to ourselves in the future. So the liver is kind of a resilient, cool organ, and it's really the primary organ when it comes to metabolism. So first pass is really important because a drug has to be able to, an oral drug has to be able to overcome first pass metabolism. If it doesn't, so if a medication gets absorbed and then gets chewed up by the liver and then nothing gets into systemic circulation, you really don't have an active pharmaceutical product. So you really have to have a medication that's proven to get through first pass metabolism. Some people who are clever make drugs that are what's called prodrugs. I'm probably jumping ahead. It's probably another slide here. But the point of a prodrug is it actually is designed to be ineffective in its original form. It goes through, hits the liver, becomes metabolized into a active form, and then is excreted. So it's actually like, all right, liver, do your worst, metabolize me. Oh, you know what? This is actually the form I want in the long run. So again, clever scientists do stuff like that. It's pretty cool, and that's what's called a prodrug, which we'll come back to those in a second. So I jumped ahead a little bit with the metabolism part, but absorption and first pass metabolism kind of go hand in hand. So anyway, you can tell I'm excited about metabolism here, but hopefully you are too. Distribution, we don't have the ability to inject a volunteer full of medicine and then grind them up and figure out weight per volume, how much there is. So we take a little bit of drug out and we try and figure it out. The problem is that doesn't really give us a good handle on what type of tissues. So if it's highly lipophilic and it's distributing to fatty tissues, it's going into the brain. If it's staying in the muscle, if it's an IM injection or whatnot, you don't ever get a really good picture on that. But the point is that we can sort of figure that out and understand that drugs will distribute with their concentration gradient. Otherwise, I don't really care. We know too much about this. The terms lipophilic and hydrophilic are important, so understanding that some drugs tend to like fat. Drugs that like fat or that are lipophilic can move around the body. They can get to the brain a lot easier. They can also accumulate in fatty tissues in certain patients if with extended exposures too. So lots of implications to that. But from a distribution perspective, this is probably the least relevant thing we're going to talk about. Distribution is it's important to a certain degree, but at the end of the day, we just have to deal with it, and it doesn't really help us out when we're trying to figure out drug dosing and stuff like that. Here's some just other points. Protein binding, muscle mass, things like that are going to change your distribution. The blood-brain barrier is probably the most important thing when it comes to distribution, because some medications you want to get into your central nervous system, whether they're psychoactive or opioids for pain management or antibiotics to treat meningitis, for whatever reason it is. The blood-brain barrier is designed to keep things out. There's lots of transport systems that we can manipulate pharmacologically, but overall, if you have something that's lipophilic, it can move directly across without any type of barrier, without any of these things impeding it. So it can just go across and it doesn't have to worry about any transport. Here's lipid-soluble agents just moving across the cell membrane, right into the central nervous system. Other medications might have to go through some sort of transport, or they might take a slower process to get into the blood-brain barrier, across the blood-brain barrier. Metabolism, defined as selecting a pharmacologic, or critical in selecting a pharmacologic agent. The whole point of metabolism is to transform a compound into something that can be excreted by the body. So the whole point of what the liver is doing is trying to manipulate molecules, add things onto them to make them overly polar, so that they can be excreted usually by the kidneys. Now they might get excreted in the bile back into the feces, or something like that, or some combination. But for the most part, our drugs are getting altered via metabolism, and the goal of alteration is to make it so that that drug gets eliminated from the body. And that's how drugs, for the most part, are removed from the system. I talked about basically every tissue has some ability to metabolize, but the liver is the 90% player here, but there's lots of other things that have capacity to do some minor metabolic work, but it just depends on what the drug is as well. I talked about first pass. What I didn't talk about yet was intestinal metabolism. So again, I mentioned somewhat about the drugs getting metabolized via the GI wall, but overall, the majority of things is going to happen once it gets to the liver. Enterohepatic recycling is kind of an interesting concept. So if something gets metabolized, it might get excreted out into the GI tract through the bile system. And then you might have bacteria in your GI tract that then alter those chemicals back into their original form, and then they get reabsorbed and back into systemic circulation. That's called enterohepatic recycling. Common drugs that undergo this would be like most different types of hormones, especially like oral contraceptives, undergo enterohepatic recycling. That's part of their duration of action. Without that, they wouldn't last quite as long, and they probably wouldn't be a once daily type medication. Spontaneous metabolism is my favorite. Some drugs just simply metabolize and they don't really go through the liver. We don't really know why. There's probably some intestinal wall stuff. There's probably some esterases floating around in the blood, but some things, very few things I should say, are avoided by the liver. So most things have to go through the liver and will go through the liver to be metabolized. So the liver enzymes, there's a couple different sets of them. The big ones that we care most about in the pharmacy world are the cytochrome P450 enzymes. These are going to be anything CYP, or what I call CYP. So I'm going to refer to CYPs a lot during the course. So this is a really, really important thing to understand now. If you need to go back and listen to it a couple times, I understand. Cytochrome P450 enzymes, CYP enzymes. So CYPs metabolize via oxidation reduction. They're also called phase 1 enzymes. There's some other hepatic enzymes that alter by conjugation or hydrolysis. That's phase 2. A lot of drugs do undergo multiple steps. So they might undergo oxidation reduction via the CYP system and then go into another system, and then finally they get excreted out once they've been altered beyond recognition. This chart here shows you the common CYP enzymes. I don't want you to memorize CYP enzymes, but I think it is very helpful to understand just the basic concepts that there's only a few CYP enzymes that make up the vast majority of metabolism that drugs undergo. So CYP 3A4, 5 and 7 to a lesser extent. 3A4 is a big one, 2D6 and 2C9, 2C19. Those four probably are the ones you're going to see a lot. So if you go into a drug monograph and you say, how is this drug metabolized? CYP 3A4, and you are prescribing a medication that alters the way that the liver uses CYP 3A4, or you maybe give two medications that are both metabolized by CYP 3A4. Guess what? The liver only has so much enzyme stored in it, so that might create a conflict where you actually end up with higher blood concentrations of both, because both of those drugs are competing for the same enzyme. So that's where drug interactions come into play. 90% of what we talk about with drug interactions will be related to interfering with the cytochrome P450 system. So that's why this is really key to understanding that component of pharmacology, the drug interaction point, which is mostly related to the CYP system. Now, glucuronidation, there's a lot of different ones of those. We don't really care as much because by the time it gets through redox, glucuronidation is kind of just like an added bonus. We don't really, again, worry ourselves with drug interactions and stuff like that. All right, so I really don't show structures a lot, so don't get worried about this. And if I do, I will never, ever test you on structures. But here's just a fun example. I think it's fun anyway, of codeine. So codeine, people most know codeine. It's a really weak opioid. It's in cough syrup, etc. Codeine actually gets metabolized into the body to morphine at about a 1 to 10 rate. It goes through a couple different processes actually. So codeine, the molecule, you take a codeine tablet or drink codeine cough syrup. Codeine gets into your system, goes into the liver. Liver is going to glucuronidate some of it off. It's going to redux some via CYP3A4. That's going to go to a product called norcodeine that's going to get glucuronidated and excreted very readily. About 10% of the codeine you ingest will get metabolized via CYP2D6 to morphine. Morphine is the active form. Codeine itself probably doesn't really do a whole lot. It's the morphine and the small amount of morphine that's going to give you the effects of analgesia and cough suppression from the actual drug. Morphine is then glucuronidated to a couple other odd molecules that, again, you can see. Here's your morphine, here's your morphine, here's your morphine. You've got these giant chunky side groups that get thrown on here that make the molecule very polar. Polar molecules are much more easy to excrete in the kidneys, and then the molecule disappears from the system. Again, this is kind of a cool example of how not only the liver removes drugs from the system, but can make an initial drug actually into a more potent version via metabolism. So kind of cool science there. Acetaminophen metabolism. So acetaminophen, Tylenol, most common drug in the world. So acetaminophen actually has a really interesting metabolic pathway. If you take acetaminophen, your liver processes it through a number of different channels. However, there's one particular intermediate called this NAPQI that normally in most people, let's say you or I took a dose of Tylenol, our body's just going to see all this stuff as the same, and it's going to process this NAPQI the same way to this glutathione intermediate and then excrete it ultimately. Now, the problem is that your body only has so much GSH, which is a specific product the liver produces to be able to conjugate the glutathione. So it's kind of a separate secondary. So again, it's undergoing cytochrome P450 here, and then you get this intermediate. If your body runs out of the GSH specific liver produced glutathione conjugation agent, you end up with an accumulation of NAPQI, which ends up causing toxicity over time, and that can cause liver damage. So if you take too much Tylenol, your body just gets to a point where it can't process it anymore, and you build up this accumulated toxic enzyme, which causes hepatotoxicity. So that's one thing to just keep in mind, that the liver has these rate limiting steps too. It doesn't have an infinite supply of resources. There are things we can do to treat this. We'll talk about that during toxicology specifically. I already talked about prodrugs. Here's an example of one though. So this is clopidogrel. Clopidogrel is Plavix. It's one of the most common antiplatelet agents we give people post-MI, post-stroke, etc. So if you give clopidogrel, it gets absorbed in the intestines. Some esterases rip off some of it. It goes to 2C19 via first pass metabolism, and then ultimately gets active into its active metabolite via the first pass system. And so you get metabolized into this active form, which is slightly different than the original compound. So again, kind of cool way to do it. Now you might think, well, what if you don't have these enzymes functional or they're being interfered with? That's a good question. So there's a lot of drugs that if you, let's say you were a really poor, some people are poor metabolizers of certain enzymes. So if you're a poor CYP2C19 metabolizer, you might not get to this point. Your clopidogrel might be extremely ineffective for you. And there's actually some genetic testing that can figure that stuff out, which is kind of cool to see if you're actually a poor metabolizer or not, specifically related to clopidogrel metabolism. And that leads us to discussions of inducers and inhibitors. So this is really what it boils down to when it comes to drug interactions. Inducers are going to cause increased enzymatic activity. These are quite rare. There's not a lot of drugs that do this, and the ones that aren't super common. Rifampin is sort of an obscure antibiotic. Carbamazepine and phenytoin are older anti-epileptic drugs that aren't used a whole lot anymore. There's a lot of drugs that inhibit the CYP system and cause decreased enzymatic activity. So these drugs may share metabolic pathways and compete against each other, or they simply just block the enzyme from happening, from occurring, or block its usage or bind to it so that it can't metabolize other drugs or something like that. At the end of the day, you get less enzyme, which means that other drugs that are relying on, or your body's relying on the liver to process other drugs, and then it can't do that as well. So you end up with higher blood concentrations of certain medications. Usually, we try to avoid any medications that have really strong CYP enzyme induction or inhibition. And if you are on something that's really heavily metabolized by a specific CYP enzyme, you want to be very careful that you aren't giving a drug, if you're starting any new drug, that it's going to interfere with those specific ones. So again, there's not a ton out there, but there's certainly more inhibitors than there are inducers. And I'll point out throughout the course which ones are the really bad culprits. Metabolic considerations. So again, I talked about individual variants. Diet and grapefruit. There is diet and environmental. Grapefruit juice can ramp up the cytochrome P450 system. You have to drink a fair amount, and you have to drink it pretty consistently. Like eating a half a grapefruit, probably not enough to do that, in case you're wondering. Cigarette smoking regularly actually increases metabolic processing, increases CYP processing, and industrial exposure can be a mixed bag depending on it. As far as age goes, elderly neonates are slower metabolizers, adolescents, young adults fast, and then kind of you taper off throughout your adulthood as you approach your elderly years. Young men tend to metabolize the fastest, association likely with androgenic hormones for an unknown reason. And disease states, hepatic, cardiac, pulmonary, thyroid, inflammatory disease can all alter metabolism. Not enough usually that we dose adjust, but it is something to consider. And a lot of this stuff is less, I mean, with kids, that's a whole different story, and we'll talk about pediatrics specifically at some point this year, next year actually. But when it comes to elderly or young adults, it's not like we give, a young man more medication. We might, or we might start them on a higher dose depending on what we're trying to do. But usually we start most adults in the same realm, and then we kind of titrate them up depending on what we think they need. And finally, excretion. The kidneys are our major players here, and they're going to take those drugs that the liver has altered and excrete them. So a lot of excretion is some other excretion might occur through things like sweating or lungs, or via the lungs, via exhale. Some might be excreted in the feces, either unchanged or via bile. But for the most part, those molecules are going through the kidneys once they've been altered. Some medications might get excreted out unchanged too. They might be polar enough as is, where once they hit the kidneys filtration system, they'll just simply get removed, or some of them will get removed over time. One thing I'm going to talk about a lot is creatinine clearance and kidney function, and I'll say things like, oh, this drug needs to be dose adjusted for poor renal function. So in medications that are heavily filtered out by the kidneys, if somebody has kidney failure, of course that medication is going to stick around in the body a lot longer. So that's where there's a lot of dosing guidelines for people with various stages of kidney disease. There are two major ways to measure the way that your kidneys process things, and so we call it glomerular filtration rate, or GFR. It's measured in mils per minute. Sometimes it's referred to as creatinine clearance as well. There's two calculations. Cockcroft-Gault is the old one that's used currently for drug dosing. Cockcroft-Gault isn't super accurate, but because basically every drug on the market has based their renal dosing off of Cockcroft-Gault formulations, we still use it to this day to dose drugs. The nice thing about Cockcroft-Gault, it's a relatively easy equation. 140 minus age times your weight in kilos over serum creatinine times 72. You multiply it by 0.85 for females, just having a lower muscle mass. Creatinine, we haven't talked about this really, so I'm kind of jumping ahead. What creatinine is it's a biomarker for muscle degradation, which doesn't really matter for kidneys, but the nice thing is that you excrete it via the kidneys. So serum concentration of creatinine is a surrogate marker for how well your kidneys are filtering your blood. So if your creatinine is really high, it means that your kidneys aren't pulling enough of it out of circulation. If your creatinine is really low, or normal, I should say, or like around 1, then it means your kidneys are probably working fine. The MDRD equation is the more comprehensive one. You can see there's a lot of odd variables here. It also takes into consideration specifically race for people of African or Caribbean descent having generally higher muscle mass than people of Caucasian, Asian, Hispanic descent. And then also it has the female multiplier as well. So it's generally thought to be a little more accurate. Some of the newer drugs you'll see coming out actually will talk about dosing in terms of eGFR, or estimated GFR, which is using the MDRD equation, not creatinine clearance. So kind of different, kind of the same. I know it's confusing. Generally speaking, for this class, the Cockcroft-Gault equation will be what I want you to remember for drug dosing. I'm not going to ask you to calculate creatinine clearance. I'm not that mean. But I do want you to know that that's what that is. So creatinine clearance is the Cockcroft-Gault equation, and that's what we use it for as drug dosing. The MDRD equation is also essentially creatinine clearance. It is measuring how much creatinine you're clearing, because that's what it is. That's your major variable here, just like in the other equation. But it's also referred to as eGFR, estimated GFR, and that's what's used to stage people for CKD staging. So anyway, that's the end of the story when it comes to that. Pharmacists spend a lot of time with this type of stuff, but it's really pretty basic. You can, in any drug monograph, you can go in and look and say, okay, what's the dosing? Click on the renal dosing option. It'll tell you, okay, if their creatinine clearance is above 60, no change. If it's between 50 and 30, no change. If it's under 30, dose reduce, or if it's under 30, don't give it at all. So there's usually recommendations for those types of things there. This is something I like to say to people. I don't know, actually I don't really say this to anyone. But the big picture thing here is, don't just look at somebody's creatinine lab and say, oh, their creatinine's high, they must have bad kidney function. Yes, you can probably tell that a little bit from seeing something like that, but you still have to do the calculation, because somebody might be really, really heavy or have a lot of muscle mass, or maybe they have some sort of muscle tissue injury going on, which is complicating things. Or if they have really low creatinine clearance, maybe it's because they're paraplegic, and that's something to think about too. So creatinine itself isn't always the best thing, although it will give you a brief picture. You do want to calculate out their clearance to figure out exactly what you're looking at. Calculating clearance is not hard. Again, this equation is really easy. There's a lot of online calculators that will do it for you. One thing I would say is, sometimes people are like, well, what if I don't have a creatinine? Plug in 1 and just see what you would get. So assuming your patient's healthy-ish and you don't have any suspicions of them having any type of kidney disease, plug in 1 for the creatinine, since that's normal, and you'll see what you get, and that'll give you at least a frame of reference. Pharmacists are kind of big into kinetics. Again, we study this quite a bit in school. So if you're ever having questions about, half-life of drugs, or clearance, or metabolism, and how it might affect, what you want to prescribe, or what types of therapies you're considering, reach out to a pharmacist. Again, it's kind of like our bread and butter specialty. So certainly don't be shy about those types of questions. All right, that's it for this lecture. We'll talk soon.